Hello and welcome back to my channel. Today we are going to be looking at A-level psychology, specifically the AQA curriculum. And this is an optional topic that I believe you take in paper 3, which is addiction. I know a lot of people have been asking for this and I have finally got round to doing it. So before we jump in, of course, feel free to subscribe, check out some of my other A-level psychology videos. If there's any other kind of content you would like, please let me know and I will try my very best to get it up as soon as possible. I've managed to crack this one out in a day. So yeah, hopefully I will be able to get more videos up for you. But yeah, please let me know. Feel free to subscribe, like, comment below any questions you have. Or of course, please let me know in the comments as well what subjects you would like. And yeah, let's just crack on with the video. So first off, starting with describing addiction. So addiction is noted in the DSM-5 in the category substance-related and addictive disorders, but the only behaviour actually included in this is gambling, as there isn't enough research into other behaviours to justify being included. Firstly, dependence. So physical dependence occurs when a person has used a substance so often and in such amount that they experience withdrawal symptoms when they stop using the substance. Psychological dependence is the emotional need to use a substance or to perform a behaviour that has no underlying physical needs, such as stopping nicotine has a longer emotional need time than physical. Then we've got tolerance. So tolerance is shown when a person has diminished response to a drug as a result of repeated use. The individual has to increase the dose to obtain the same effects as the initial response. This is a physical effect of repeated drug use, not necessarily a sign of addiction, and this can take place with both legal and illegal drugs. Obviously, you hear a lot about people becoming addicted to legal medications they're given. And the level of tolerance is different for different effects of the substance. So, for example, using cocaine, certain levels, you can receive certain levels of euphoria versus, how your body can tolerate the damage it causes to the respiratory system. Then we have withdrawal symptoms. So withdrawal occurs in drug and alcohol addictions for those who can discontinue or reduce use. This is because the brain has adjusted its functioning to the presence of the drug, and when this level drops, the brain seeks out. Psychological symptoms can include depression and anxiety, and physical symptoms can include nausea, loss of sleep, and weight loss. So looking more now at actual risk factors for who is more at risk of developing an addiction. So first we've got genetic vulnerability, going back to that beautiful nature-nurture debate. In terms of genetics, so individuals can be predisposed to becoming addicted to some substances as they can influence how the substance is metabolized, so changes how the body responds by enhancing positive or negative effects. An example of this is the fact that Europeans metabolize alcohol quickly so they don't get as sick, but 50% of Asians metabolize it slowly and easily become nauseous even after having just one drink. Then a couple of strengths of this, so research support. For example, Kendler et al. In 1997 did a Swedish male twin study who found a genetic disposition to addiction, or Kendler et al. Again in 2012 found children with addicted parents who had actually gone on to be adopted were 9% more likely to become addicted. The key with the first one in 1997, if you do use this as a support, a counter argument for it is the fact that it is Swedish males. That is not a representative sample, so it's not the most reliable study. Also, research findings suggest environment is still important. For example, in the Swedish male study, in both those studies, just specifically the 1997 Swedish male twin study, the results were not 100%, which suggests that environment is still important. It's also quite biologically reductionist. It's not quite as simple as that. And again, determinist as well. Then we've got stress. So high levels of stress make people more vulnerable to addiction. They may turn to substances or behaviour that gives temporary relief as a coping mechanism. However, addiction is less likely with other mediating factors like social support. Stress can also relate to social environment like family, but also where people live. Those in cities are more likely to be addicted to drugs, but this could also be because it is more readily available. Stress could also be due to personal or childhood trauma. So a couple of strengths of this kind of idea. So research supports, so Epstein, 1998, women with a history of childhood rape had twice as many PTSD symptoms as those who had not been raped, and childhood rape victims are twice as many alcohol-related symptoms compared to those with no. Okay, that sentence doesn't make quite sense, but I'm sure you can figure it out. And then Tvaltia et al., apologies if I mispronounce anyone's names, in 2013 found highly stressed uni students were more likely to smoke, abuse alcohol, and high risk of addiction to the internet. Although part of this is that they measured stress using a questionnaire, so there's potential social desirability in this, so again, impacts the reliability of the study. Then moving forward, another risk factor is personality. So Eysenck in 1997 proposed that some personality types were more prone to addiction, such as high neuroticism, so this is high levels of irritability and anxiety, and those with high psychoticism, aggressive and emotionally detached. This theory is now rejected by most psychologists as this link is still being investigated, and a key factor is impulsivity, so lack of planning, risk-taking, and desire for immediate gratification. Support for this comes from Ivanov et al. In 2008, showed a strong link between impulsivity and drug use, and also could help identify individuals at risk of developing addictions and provide help before this happens. So it has some real life application, because you can help try and prevent addiction in people with certain personality before it happens. The influence of peers as well is greater than the influence of family, according to Quinn and Stevenson in 1990. O'Connell suggested that there are 3 features that lead to addiction. So 1, an individual is influenced in his drinking or use of drugs by associating with peers who themselves drink or use drugs. These peers provide opportunities and possibly access to drink or using drugs. And the individual overestimates how much the peers drink or use and increase their own consumption to keep up. A few negatives to this. So 1, firstly, it's very difficult to test the influence of peers. It's not something that you could easily test, and observations are a lot harder, because how many teenagers are going to want to let a load of researchers sit there whilst they do cocaine? But you know what I mean. Influence varies in importance based on age. So again, like I just said, teenagers are much more likely to be influenced than someone who's 25, for example. And also does not take into account other social factors such as social deprivation, unemployment, and stress. So these are all really important things, again, obviously kind of relating to other factors. Then specifically looking at family influences, so you've got the social learning theory. So the individual observes their parents smoking, drinking, etc., and the results of this behaviour. So a parent can feel more relaxed or experience pleasure. And so the individual, the actual child, is looking at these and wanting to take part in this behaviour to imitate and get the same results. A couple of negatives, so cognitive factors mediate whether the child will smoke or not. There are other factors at play. Apologies for any spelling errors, by the way. Including peers, health messages, and age. And also depends on how the individual identifies with the behaviour. Just a personal example, growing up, my parents both smoked, but they were very, very clear they did not want me and my siblings to smoke. And as we grew up, I have never smoked, whereas my sibling smokes quite a bit. So again, family influence, very different, and especially in terms of identifying with the behaviour. Then you've got perceived parental approval. So the adolescent perceives that their parents have a positive or permissive attitude towards a particular drug or addictive behaviour, such as gambling. This may be based on parents taking the drugs themselves or not monitoring their own behaviour or their child's behaviour, such as, having alcohol at home and things. Quinn and Stevenson, 1990, with Australian children. If the parents drank at least weekly, their children were more likely to have the intention to drink. And also Bonomo et al. 2001 found adolescents with alcohol-related injury were 1.8 times more likely to have parents who drank alcohol daily. On the other hand, again, it's difficult to separate all these different influences from peers, media, etc. So again, it's quite hard to test, and there can be a lot of other things at play. So firstly, looking exactly at explanations for nicotine addiction. So we are going to be looking at brain neurochemistry first. We've got the desensitization hypothesis. So we've got ACH. I'm not even going to try and pronounce that neurotransmitter. But yeah, that's a neurotransmitter which, like all neurotransmitters, bind with receptors and activate post-synaptic neurons. One subtype of ACH receptors is called nicotinic receptors. They bind with both nicotine and ACH. When nicotine binds with the receptors, the neuron becomes stimulated. However, almost immediately the receptors shut down and the neuron does not respond to any neurotransmitters, aka desensitization. This also leads to the production of dopamine in the nucleus accumbens. This generates a pleasurable feeling, increased alertness, and a reduction of anxiety. A couple of strengths to this. So Domino in 2004 used fMRI scans showing a change in blood flow in the nucleus accumbens, amygdala, and hippocampus immediately after smoking the first cigarette in the morning. After the second cigarette, the effects were less. Zhu and Marku, 2013, found that by blocking the transmission of glutamates in rats, they reduced their addiction to nicotine. I'm just going to say it as well. I'm so glad that the exams were never, verbal. I'm so glad I wouldn't have to try and rely on saying any of these names in an exam. But anyway, back to this. So a negative of that study is the fact that it is an animal study. Obviously, that's not reliable. Rats have very different brains to humans. Otherwise, they would be building planes and not being in cages like we humans have done to them. And then you've got the nicotine regulation model. So when the smoker does not take nicotine for a prolonged period, it is metabolized and excreted, and the nicotinic receptors become sensitized again, giving rise to feelings of agitation and anxiety, which would be the withdrawal symptoms, which then motivates them to smoke again. The ACH increased transmission is accompanied by a decrease of dopamine activity. The repetition of this cycle creates a chronic desensitization of the nicotinic receptors, so the intake of nicotine has to increase to produce the same effects. Tolerance. Furthermore, the prolonged use of nicotine results in an increase of the number of nicotinic receptors. Nicotine also stimulates the release of glutamates, which also increase and speed up the release of dopamine, thus increasing the reward effects of nicotine. Some strengths of this, so studies of patients with Parkinson's disease. This disorder is due to the loss of dopamine producing cells. Smokers are less likely to develop Parkinson's than those who don't smoke, but that is not a reason to start smoking. If you're worried about Parkinson's disease, don't smoke and avoid it. Health warning, health note, health message, whatever. Another strength comes from Cosgrove et al. 2014, compared brains of men and women using PET scans while smoking, and the dopamine effect took place in different brain regions, suggesting that men and women smoke for different reasons. Apologies for the spelling errors. Research suggests, on the other hand, that other neurotransmitters are also involved, such as serotonin and GABA. So it's not purely just dopamine that's involved. And again, it's very reductionist, makes it seem very, very simple when it's not quite that simple. But if we move forward just to specifically look at the nicotine regulation model as a kind of image, so, you've got the intake of nicotine, you become desensitized to it, and you have a release of dopamine. You feel good, you feel alert, you have reduced anxiety. Then that's metabolized and excreted, so your levels decrease. Your receptors become sensitized again. Then the withdrawal symptoms start kicking in. And again, you have the cycle intake, and then you become sensitized and desensitized. Then we've got some more theories behind nicotine addiction. So this time we're more looking specifically at learning theory. So imitation is the form of social learning theory. Then we've got maintenance of the behaviour, which is operant conditioning, and relapse, which is classical conditioning / cue reactivity. So social learning theory, this suggests people begin to smoke due to learning from their social environment. They observe people and the consequences of the behaviour, including positives such as looking cool, feeling relaxed. Mayu et al. 2008 carried out a longitudinal study and found positive correlations between smoking at 16 and popularity 2 years later in boys, but a negative relationship between smoking at 16 and popularity at 18. Popularity might act as a vicarious reinforcement rather than direct for boys, but not for girls. Strengths of this: de Blasio and Bender in 1993 found adolescents who smoked associated with other smokers and more likely to conform to the social norm of a smoking group. And then also, obviously, the real-life application to prevent smoking. If you know how it's getting started, then you can implement ways to prevent this. Then also it does not account for... Let me start that again. The theory accounts for motivation to start smoking, but not the continuation, despite consequences such as costs, health warnings, etc. Then we've got the maintenance, so this is where operant conditioning comes in. This explains why smoking continues after initiation, as they get positively reinforced by the actions of nicotine on the dopamine reward system. Nicotine leads to the release of dopamine in the nucleus accumbens to produce a mild feeling of euphoria, thus rewarding. Not smoking leads to agitation and anxiety, aka negative reinforcement. And obviously, when you're smoking, you want to avoid feeling agitated and rubbish, so you're just going to have another cigarette to get past it. Strength for this research support comes from Levin et al. In 2010, trained rats to self-administer nicotine by licking one of two water spouts and saw the effects of nicotine reinforce the behaviour of taking nicotine. However, again, it's an animal study, so it's not reliable, and the study only used nicotine when actual cigarettes contain a lot more than just nicotine, so there can be a lot more at play influencing how people respond to it. Then we've got the kind of relapse side of things, so classical conditioning / cue reactivity. So this is the theory that people associate situations / places with the rewarding effects of nicotine, which can trigger a feeling of craving. For example, when you go to a nightclub, obviously a lot of you watching these videos will not have been to a nightclub, but there are smoking areas there, and everyone in that area is smoking. And even if you're not smoking, you're suddenly there, surrounded by all these people smoking. You're thinking, maybe I should have a cigarette. These then become smoking-related cues. Nicotine is the unconditioned stimulus, and the pleasure of the sudden dopamine increase is the conditioned response. The stimuli associated with nicotine was a neutral stimuli before learning took place, which then became a conditioned stimuli. This produces a conditioned response, and if the nicotine is not received, then the individual will experience withdrawal symptoms. This fully explains the maintenance of smoking and the relapse in those who gave up smoking. And Carter and Tiffany in 1999 completed a meta-analysis reviewing 41 cue reactivity studies and found dependent individuals reacted strongly to the cues presented and reported craving and physiological arousal. A strength of this theory in general is the kind of practical application, so it's supported in the development of aversion therapy, for example, which we will discuss later. But on the other hand, it doesn't explain differences in why some find it easier to give up smoking or actually do not become addicted entirely to nicotine. And also it's just very deterministic and does not take into account, negative, pardon that notification, doesn't take into account negative environmental factors either. Now we've got explanations for gambling. So again, we've got social learning theory. So social learning theory suggests people begin to gamble due to learning from their social environment. Again, observing people take place in these behaviours and the consequences. For gambling specifically, there's enjoyment, there's winning money, which is a vicarious reinforcement. And then people want to imitate that behaviour. They want to feel that enjoyment themselves. You've got operant conditioning. So gambling is maintained by direct positive and negative reinforcements. Then you've also got actually continuous versus various ratio reinforcement. So continuous is obviously where every time you perform the behaviour, you are getting that positive reinforcement. Whereas various ratio reinforcement is partial reinforcement, where the behaviour is unpredictably rewarded, meaning the behaviour took longer to learn, but was then very resistant to extinction. So once that behaviour is there, it's very hard to get past. When it comes to gambling, you won't get rewarded every single time, but that one reward reinforces the behaviour. So this is essentially what it is. With gambling, you're only getting partially reinforced. You're only winning sometimes, or even getting a near win can actually feel as though it was a win, which I think we discussed a little bit. But So this doesn't explain why people continue gambling even after losing more often than winning, and also doesn't really massively explain why people start. It's also very reductionist. On the other hand, Park and Griffiths 2004, again, yes, like I was just saying, found that a near win gives rise to similar reinforcement as actually winning, which I think is really interesting. Feeling like you're on the verge of winning a ton of money is enough to make you be like, oh, let's just keep going. And then also practical applications, again, aversion therapy to help people overcome their gambling addiction. Then we've got cognitive theory to kind of explain this addiction. So this explains gambling in terms of rational maladaptive thought processes. So gambling can be explained by cognitive biases, which sees a pattern of thinking and processing information about the world that produces distorted perceptions, attention and memory of people and situations around us. These operate at an automatic and preconscious level but influence attention and memory. Rickwood et al. In 2010 identified 4 categories of cognitive biases. So you've got skill and judgment, which is the tending to overestimate the amount of control they have. Personal characteristics and rituals, so believe themselves to naturally be more lucky or engage in rituals to bring luck, such as, having a lucky number, or you've got to wear a certain pair of pants on a certain day of the month, or you've got to have a rabbit's foot in your pocket. 3 is selective recall, so the tendency to overestimate wins and underestimate losses. This kind of relates to the near win kind of idea, like you're overestimating, like you're so close to that win, you're overestimating it. But when you all those like 20, 30 times that you've lost in a row, it's all right. I'll be all right, Griffith 1994 found that gamblers saw themselves as more skillful than non-gamblers, when in actual fact there was no difference in their ability to gamble. Although on the other hand, it does not explain gender differences in gambling habits, and again, very reductionist. Now, when it comes to reducing addiction, one option is drug treatments. So there are 3 types of drug treatments. You've got aversive drugs, so these produce unpleasant consequences, such as vomiting if taken with specific drugs to counter-condition the behaviour. Agonists, which are drug substitutes as a less harmful replacement with fewer side effects to allow a gradual and controlled withdrawal, such as, for example, a common thing that you always hear about is methadone as a treatment for heroin addiction. Then you've got antagonists, which block the neural receptor sites so the drug can't have its usual effects. For nicotine, you've got nicotine replacement therapy, NRT, which is using patches, gums and inhalers, the things you tend to see adverts for, you'll see them in the supermarket, to deliver nicotine in a less harmful and more controlled way. It stimulates the nicotinic receptors to release dopamine, but over time the nicotine amount is gradually reduced, so withdrawal is managed over a period of 2 to 3 months. Steed et al. In 2012 found that those using NRT, their chances of stopping smoking was 50 to 70% higher, with minimal difference in effectiveness for the method of NRT. So essentially what that means is, regardless of whether you use patches, gums or inhalers, they're all generally as effective as each other. And there is no specific drug for gambling, although in the US they do use naltrexone, which is usually used for heroin treatment due to its nature of releasing dopamine. The issue with using this drug is it reduces the release of dopamine, so it can also impact enjoyment in other areas of life. SSRIs, so selective serotonin reuptake inhibitors, if you've studied anything to do with depression and things, you'll have come across this there as well, can also be used as serotonin associated with impulse control, which is supported by Hollander et al. In 2000. A kind of positive and negative is drug treatment is cheaper than CBT, so it's a lot more accessible to people, especially in the UK where a lot of medications could come from the NHS, but there are ethical issues and side effects. Obviously, if you're having a drug, so every time you smell something or take something, you are horrifically vomiting, it's not exactly great. It can be really damaging and actually stop your body from being able to take in everything it needs to be healthy. And another positive as well is actually the fact that this blames biology and helps to remove the stigma and blame culture of addiction. It's not suggesting that there's anything wrong with the individual in particular. But these actually may not be as effective without the psychological intervention and does not address cognitive biases. There's a reason these individuals got addicted in the first place, and just having drugs does not necessarily fix the psychological pathways that got them to where they are. Then we've got behavioural interventions. So firstly, aversion therapy, which we've discussed a little already, but this is based on classical conditioning. So two stimuli become associated when they occur frequently together. So drug, alcohol, behaviour become associated with pleasure. Aversion therapy uses the same principle but changes the association and replaces pleasure with an unpleasant state, also known as counter-conditioning. So this kind of relates back to the aversive drugs, where they produce unpleasant consequences such as vomiting. So you begin to associate the vomiting with the drug or behaviour that you're interested in. So for drug and alcohol, individuals are given an aversive drug to cause vomiting, nausea when they smell or consume their addictive substance, or they can use a disulfiram, which interferes with the metabolism of alcohol. So essentially this just makes the hangover horrible and extreme, with severe throbbing headache, increased heart rate, palpitations, nausea and vomiting, obviously in the hope of getting you away from drinking because you're like, I don't want to have that really bad hangover tomorrow. But obviously a bit more extreme than that. For gambling, electric shocks are used to cause pain, but not necessarily any damage to the person. The individual reads gambling-associated statements and then receive an electric shock when they read them, but the individual sets their own intensity for these electric shocks. Then we have covert sensitization. So more common than aversion therapy, this is where the individual imagines how it would feel to experience those electric shocks or vomiting. So also known as in vitro conditioning. They are asked to relax and imagine an aversive situation and think in detail how this would feel. They then imagine themselves doing the smoking, drinking, gambling whilst with the unpleasant consequences. So I saw an example of this was to sit there and imagine that your cigarette is covered in feces, or, to imagine yourself throwing up after you've had a drink. So it's essentially, covert sensitization is essentially aversion therapy, but you're not actually forcing yourself into that scenario where you are causing yourself actual physical pain, but instead you just imagine it and put yourself into that scenario, but also keeping your body physically safe. One strength of this, Mayo and Chester, so in 1970, found that aversion therapy helped 50% of alcoholics abstain for at least a year. Ashem et al. In 1968 found 40% of alcoholics abstained 6 months later after covert sensitization, and 90% of gamblers had reduced their activities, according to McConney et al. 1983. However, compliance can be low. Obviously, this takes a while. It takes a long time to do this and a lot of commitment. And also, there's ethical issues, obviously, to physical harm, loss of dignity. In these kind of situations, people can be vomiting immediately, especially in public places. So yeah, it's not exactly the most pride-fulfilling situation. Then another way of reducing addiction is CBT. So CBT identifies and changes the way people think about their addiction, functional analysis, and helps clients to develop strategies to avoid situations that trigger addiction behavior, skills training. So functional analysis, the client and therapist identify situations where they are likely to perform addictive behaviors and exploring thoughts and motivations before, during, and after the event to identify cognitive distortions/biases. The therapist then challenges this and is ongoing. So this is an ongoing part of the therapy. And then you've got skills training. So this cognitive restricting helps clients in modifying their irrational beliefs and cognitive biases. Specific skills enable the client to cope in a given situation, which varies per person. And social skills help people avoid situations likely to result in a relapse in addictive behaviour. The therapist explains and models for the client to imitate within their sessions. So, for example, with the skills training, it teaches the client to have the skill to be like, no, I'm not going to go to that massive rave with you later because I will definitely go and relapse. So that's an example. But yeah, it teaches them the skill to avoid those kind of situations that aren't safe for them. A strength of this is Lujusier et al. In 2001 found 86% of gamblers in CBT groups reduced their gambling to the point where they were no longer defined as addicts, and this was maintained a year later, and as well provided skills to resist social pressure, unlike other therapies. However, on the other hand, Kowalshaw et al. 2012 reviewed 11 studies and found no difference after 12 months. Again, it requires a lot of time and commitment, and finances are not always available to those with addictive habits. Obviously, a lot of people, not to stereotype, but just a general kind of piece of information, a lot of people with especially drug and alcohol habits don't necessarily always have a lot of money. I'm not saying that's the rule for everyone. There are a lot of people with addictions that have a lot of money, but not everybody does. So yeah, CBT is not always available, and it can be very, very expensive, and also does not take into account biological factors. Obviously, this goes to that fact that people can be more genetically disposed to having an addiction, and it just doesn't take that into account, which obviously again makes it harder for people to potentially quit and get over that kind of hurdle of addiction. Then we've got application of behaviour change theories to addictive behaviour. So first up, we've got theory of planned behaviour, TPB, developed by Asgen and Fishbein in 1975, that proposes an individual's decision to engage in a specific behaviour, such as gambling or stopping gambling can be predicted by their intention to engage in that behaviour. Intentions are detailed by 3 variables. So you've got personal attitudes, so our personal attitudes towards the particular behaviour, the sum of our knowledge, attitude and prejudice. For example, smoking makes me feel relaxed, but it also smells bad and costs a lot of money. Then we've got subjective norms, so considers how we view the ideas of other people about specific behaviours, so the attitude of our family towards smoking. And then we've got perceived behavioural control. So this is the extent to which we believe we can control our behaviour, also known as self-efficacy, dependent on our perception of support available and our own determination. Our perception of behaviour control has 2 effects. According to this theory, it affects our intention to behave in a certain way and affects our behaviour directly, as if we perceive a higher level of control, we will try harder and longer to succeed. A strength of this theory, so TPB is the model most used in health psychology and useful in predicting intentions relating to smoking and drinking. Penny in 1996 also found smokers that were less likely to believe they would quit and therefore less likely to try the more times they failed to quit. Webb et al., on the other hand, in 2006 only found a small link after a meta-analysis in 47 studies and does not take into account the role of emotions, which are obviously again important for influencing behaviour. So here's just like a little figure of how the theory of planned behaviour works. So background variables going towards subjective norms, intention, behaviour. You've also got attitude, perceived behavioural control, and feedback within there. Obviously the feedback from the behaviour to the background variables going towards the norm, very, very important. But that's just kind of, if you find it easier to wrap your head around kind of picture versions of these sort of theories, then this is definitely a really good one to have a look at. Then, just to finish up, we have the application of behaviour change theories again, but this time we have Prochaska's 6-stage model of behaviour change. So Prochaska and De Clemente in 1983 noticed a change from unhealthy behaviour to healthy behaviour. It's complex and involves a series of stages not taking place in a linear order and often cyclical. So if you study relationships, you'll recognise this from the stages of relationship breakdown. You have the stages, but they won't necessarily go in that order, and you can go back and forth between them. So starting off with pre-contemplation, at this stage people are not considering changing their behaviour in the near future, likely in denial or demotivated by previous failures. This stage should involve helping them to realise they have a problem. Then you've got contemplation, so increasing awareness of a problem, and consider the costs and advantages of changing at this stage, help the client to see that the pros outweigh the cons. Then in third, we've got preparation, so decide to change, but no plan on actually how to do it. So at this point, you want to help the client decide what support they will need to successfully change that behaviour, would that be medication, therapy, etc. Then you've got action. So this is actually when people change their behaviour. Relapse can happen at this point, and you just need to be able to support them to maintain this change. Then you've got maintenance. The change has been maintained for at least 6 months at this point, and the individual is growing in confidence that the change is permanent. Now is the time to focus on preventing relapse. And to finish off, we've got termination. So the change is permanent and stable, and there is no relapse. But it's still good to show support at this point in time as well. Just because they've got to termination doesn't mean they might not still fall behind at points. The good thing about this model is that it's flexible and dynamic, and allows for more individualized interventions, which are more likely to be successful than one size fits all, because of the fact that it's so flexible. People will move back and forth, and you have to kind of take appreciation of that. But on the other hand, research is inconclusive as to whether this is effective or not, and neglects to consider other influences. A lot like the other theories that we've kind of looked at, it doesn't take into account poverty, unemployment, living conditions, etc. But that is everything. That is the addiction module. That's everything. I really hope you enjoyed. I hope you found this really, really helpful. Please, of course, always let me know if you have any questions down below, and I will try my best to answer them, or potentially your fellow students may get to them before I do. But yeah, I will speak to you soon. Bye.